Hey guys, good evening and welcome to Cozy Talks Live. I'm a little bit of a different angle here with my show tonight. I have a plant I am nursing, and I know that sounds incredibly crazy, but it is taking up where I normally perch for the show for tonight. All right, let's go ahead and get started and see who is on board. Guys, if you are watching the replay, hit replay in the comments section. Send me a shout out. Let me know who you are, where you're from, and any questions that you may have. But for the moment, let's say hello to the people who are on board. We've got Ken on here. Let's see. I feel like I've settled in on my walking. I still have a slight limp. It's kind of frustrating because I want to walk clean and I am an above the knee in the shorter side. Any advice? Yes, Ken, I will have some advice for you in just a moment. We're going to say hello to everybody else here on board. We've got Eric with his brisk tea. Emily saying it is hot in Central PA with Mountain Dew summer freeze tonight for her. Chuck is also here. Oh, Chuck, I got the picture of your prosthetic socket and I think it's so awesome. Keep your eyes peeled on my posting for tomorrow. We got Scott coming in from hot West Virginia, cold water in a cup. We got Marty here from Texas, who also sent me an amazing picture. Thank you again for sending me these pictures, guys. We've got Dave coming in from Lewes Beach in Delaware. We got Susie on board. Oh, Susan with Marshall next to her, sound asleep on his back, hugging his cooling mat. It sounds like everybody has got the heat, and I still have I just realized I still have my sunglasses on from today. Yes, it is officially summer. We are done with pre-warming this oven here in Florida. We got Christy coming in from Auburn, Nebraska. Brian Bishop with his Ice Bustelo. Man, cheers to you, Brian. I wish I could have some iced coffee right now. I didn't have time to fix any. We got another Scott coming in here with a pin socket, starting to head for boating pools and beaches. How do you keep your leg and liner from filling up and floating out of the leg? Not interested in losing leg to the bottom of the river or the ocean. I do not blame you there. We're going to get to that question too as well, Scott. We got Daniel coming in on board from hot and humid Kansas City. Earl coming in from California. We got a lot of new folks here. Tamara in from California. We got Linda from New York. We got Sherry from Orlando, and it's hot, hot, hot. You said it, Sherry. Pastor David, I got your question here, Pastor David, ready for you tonight. We got Rob with coffee in his cup. When am I coming to Rehoboth? That is a fantastic question. I just got back from Colorado Springs, spent the last week there. I am in love with Colorado. Had a beautiful chance to take one of my daughters to the Air Force Academy summer seminar that she was accepted. So that's a proud moment for me as a mom. I've got another daughter who has an almost full ride scholarship to university for this fall. So lots of exciting things going on in my household. As far as travels are concerned, I will not be traveling to Maryland this summer. I am so sorry, Dave, but I am going to be having ice cream with you someday at Rehoboth Beach. Let me give a shout out. We got some folks on board for Instagram. Instagram's just a little quiet this evening, but that's okay. We still love our Instagram folks. All right, guys. So for those of you who are wondering, who is this crazy woman with red crazy, I know these are my crazy sunglasses. I know, I couldn't help it. Loved them. Welcome, guys. My name is Cozy Belloso. I am a physical therapist here in hot, sticky, humid, and now lightning Tampa, Florida. I'm looking at a fantastic lightning storm right here outside my window, so hopefully the connection will last. Tampa is the #1 lightning capital of the world. Oh, yeah. Claim to fame right here. So guys, I am a physical therapist. I've been a PT now for a little over 23 years, and working with amputees in the limb loss community is my passion. Yes. So how about Richmond? Oh, no, Harsh, unfortunately, I don't think Richmond's going to be in my future for the rest of this year. I'm pretty booked with the trips this year, and unfortunately, Richmond was not on the tally this year. A little sad about that one. Hey there, Ed. There's one of my wonderful colleagues, physical therapy colleagues from Johns Hopkins. I always like to give him a shout out. He's a wonderful friend and mentor right there. So guys, didn't have a show last week because like I said, I was over in Colorado Springs hanging with family, enjoying the high altitude elevation. Holy cow. Did any of you guys like see the post I did from Pikes Peak? Can I get a shout out in the comment section? Did anybody see that post? I thought it was kind of a cool post. So for those of you who are not familiar, Pikes Peak is a humongous, the top of the summit of the mountain over in Colorado Springs. It is over 14,000 feet in elevation. So for someone who lives at sea level, That was insane. That was totally, totally insane. It was gorgeous, absolutely stunning and gorgeous. But for those of you who have been to higher elevations, you know that the higher up in elevation you go, the less amount of oxygen that you get. So I was able to do kind of a cool post because I'm a nerd, and I took my O2 sat monitor with me. And I had 5 kids with me, and we were all up at 14,000 plus feet of elevation, taking our oxygen rate. And it was kind of interesting to see how everybody varied. Mine was in the high 70s, and my lips were turning purple. But it's just interesting because I've worked a lot with patients who have cardiac issues, CHF, pulmonary issues, and this is, I imagine, part of how they feel. So it's just kind of something that sprung to mind, and that's kind of why I did that live show. And speaking of which, tonight we have a lot of cardiac questions on board, which is kind of cool because I don't get a chance to kind of dive into the cardiac side of things too much. And sometimes folks forget, as a physical therapist, we treat everything. We treat everything. And I was very fortunate in my training that I worked pretty much in every specialty that a physical therapist can work in, with the exception of vestibular rehab. I never dipped my toes there, or in pelvic floor rehab. So I know just enough to be able to refer people there and to know that it's a very important aspect of women's health. But those are the only 2 specialties. I've worked pretty much in every other specialty for physical therapy. And I did a lot of cardiac. I worked heart transplant. I worked in the cardiac ICU units. So, like I tell my patients and I tell my incoming new physical therapists and students, an amputee is not just an amputee. A lot of times there's a lot of other underlying medical issues involved as well. And cardiac is one of those. And then obviously as we age as amputees, and as you age, you may run into cardiac problems. So as a physical therapist, we got to stay on top of that as well. Emily says she saw it. John C. coming in from San Diego. Daniel says he saw it, made me homesick to go to Colorado next week to see the Blues Travelers at Red Rocks Amphitheater, 4th of July. That is awesome. Daniel, I got to tell you, as far as shows are concerned, the Flying W Ranch, and anybody who's ever been to Colorado Springs, you know what I am talking about. I had the best time listening to some of the best Western music. And I was educated that there's a difference between Western and country music. Can anybody tell me the difference? Because I just learned this past week, and I thought it was very cool. Robert says, I finally made it 5 miles on my leg. Congratulations. Cardio and strength training helped me achieve this. This is amazing, Robert. Truly, truly amazing. Guys, let me just go ahead and pick up those first questions that came in. Let me scroll back here. All right. So Ken started off saying he feels like he's settled in his walking, but I have a slight limp, kind of frustrating because I want to walk clean. I am an above the knee in the shorter side. Any advice, Ken? So Ken, typically when people say they walk with a limp as an amputee, probably the most common gait deviation or limp, that's how, it's the fancy word for it is gait deviation, is the Trendelenburg gait. That's probably, if I had to pick the most common impairment in how people walk with a prosthetic device, especially for my above the knee amputees, it's called the Trendelenburg gait. And I'm going to type that in. Let me make sure I can spell it correctly. I always forget if it's B-E-R-G or B-U-R-G. Trendelenburg gait. So what's that a fancy word for? It means that your glute medius is weak. What's your glute medius? Bob here is kind of sort of going to show us. So for those of you who haven't met Bob, here's Bob. He is my snarky and somewhat reluctant model, right? So your glutes, you got several glute muscles. You have glute maximus, glute medius, and glute minimus. Glute maximus, the biggest one, helps power your gait forward. Underneath your glute max, you have the glute medius and the glute minimus muscles. And those are there to help stabilize your pelvis, okay? Now, when you become an amputee and you lose the ability to use your lower leg muscles, the glute muscles have to pick up more of the slack. They have to pick up more of the slack for powering your gait and also stabilizing your gait, okay? Especially for my above the knee amputee folks, okay? So what happens is sometimes when your glute medius gets weak, when you are walking, you have kind of like this little lurchy type limp or gait deviation. Okay. I very rarely meet an amputee, whether they're below the knee, above the knee, unilateral, bilateral, that doesn't have a smidgen of weakness here in the gluteus muscles. Okay. And again, it's because those muscles, not necessarily sometimes they're not even because they're weak, it's just because they have to take up that much more of the slack for walking. Okay, Ken. So again, without testing you, without watching your walk, without analyzing your gait pattern, it's going to be hard for me to pinpoint what is causing your gait deviation, but I'm willing to bet my lunch money that there's going to be some glute medius weakness involved. And again, Ken, when it comes to the analysis of the gait, analysis of human locomotion, this is where your physical therapist is absolutely key and crucial. This is our bread and butter. This is where we wave our nerd flags way high. This is what we dedicate our professional lives to studying. I've been studying the human gait cycle for the past, holy smokes, 30 years. I'm not going to now I'm feeling old. I've been studying the human gait cycle for 30 years. Okay. And I feel like I still scratch the surface. But I guess my point is, if you have access to a physical therapist, that is who can really analyze your strength, your range of motion, your balance, your coordination, your gait pattern to really suss out what is it that is causing that gait deviation. Okay. So I would highly, highly encourage you to do so. And Ken, if you're still on board and you want to let us know what town, what state you live in, and maybe you'll get lucky tonight and somebody here knows of a therapist in your area that can help you out with this. So hopefully you're still on board listening. Let's see what else we got. There was another question. Where'd it go? Scott says, I have a pin lock socket, and starting to head for boating pools and beaches. How do you keep a leg and liner from filling up and floating out of the leg? Not interested in losing the leg to the bottom of the river or the ocean. I don't blame you, Scott. No joke. We've had at least, because Tampa, Florida, water, bay, ocean, shenanigans happen, right? And I remember there was a gentleman probably about a year or two ago that he was parasailing over Tampa Bay with a $150,000 microprocessor knee, and he lost his knee into the bay. Gone. Bye. Yeah. It was one of those moments. And it's funny because I had several people in my area that texted me or messaged me and said, was that your patient? And I said, no, that wasn't my patient. Because I would have told him to at least put a lanyard or something on that leg. But I felt really horrible for him because, that's an incredibly expensive leg. And as a, I don't have to tell you guys what happens if you lose your leg, right? So Scott, if you have a pin lock socket, that's already a pretty good suspension system right there, especially when you get that pin in there. But yes, if water gets into the liner, then you're going to lose that and it's going to lose the suction and off the leg comes. And again, this is something that I haven't found a perfect case scenario on how to keep a leg on perfectly. Pin lock is definitely the first choice when it comes to really keeping that leg secure. Sometimes also putting on an external sleeve. And again, I really need to, so it's a sleeve that goes, it's like a neoprene sleeve. And it's called a suspension sleeve, and it goes on top of the socket. And especially if you're below the knee, it'll be placed here. It goes over the socket, over the knee, and onto your thigh. Same thing with it as an above the knee amputee. Wait, do I have it here? I do. Okay, yay. Okay. So here, suspension sleeve. And again, it looks like a liner and it kind of even feels like a liner, but it's not a liner, right? You can tell because it's open on both ends. Okay. So one way, this is just an extra, this is what we call secondary suspension device, would be to put this on top. Now, I have seen people duct tape their legs on. I'm not going to recommend that because obviously duct tape can do some serious damage to your skin. Not to mention if you have hairy skin, oh my gosh, I can only imagine how much that hurts. But I have seen some really gnarly dudes that they have duct taped their prosthesis to their residual limb, usually because they're going surfing. So they're doing anything they possibly can to keep that limb on. Again, as a licensed physical therapist, I cannot officially make that recommendation because that duct tape would kind of tear up your skin. I would say definitely talk to your prosthetist. Prosthetists, especially if you're in a state like Florida, are really good at helping keep legs on. But again, External sleeve would be my first choice after that pin lock to help it out. All right, let's see what else we got going on. We got a lot of questions to go through tonight, guys. So I hope you guys are comfortable and I hope you have your drink on hand. Let's see what else we got. Hey, Andrea on board. Andrea, I've got your question as well. She is my resident occupational therapist. Benny says he is packing for Bismarck, North Dakota, USA Patriots Kids Camp Tournament. I love it, man. Ben, you are probably one of the most active people I know, and I love how you give back your time to these kids. It's absolutely wonderful. Robert says, even now I have a slight limp, so keep positive and you will get there. And again, guys, when it comes to the gait deviations, in some cases it's a lifelong pursuit. My buddy Reggie Showers, he's a bilateral below the knee amputee. He's been one for over 40 years. He's an amazing individual, incredibly active. And, he says with prosthetic devices, we're trying to recreate divine design with man-made materials. Okay. And as good and as amazing as our technology is, we're never going to achieve that. But I will always encourage my patients and you all as my viewers just to keep working on your gait. And it's more from a fitness standpoint. The more you're working on your gait, the better your fitness will be, right? Because to work on your gait, you got to work on strength. You got to work on range of motion. You got to work on balance and coordination. And that's something you should be doing your whole life, period, whether you're an amputee or not. Let's see. Glenn says, I put a life jacket on my leg when I jet ski. There you go. In case it falls off, it can float to the surface. A waist belt, Linda says, will also help. You can have clips put onto the socket. Yes. We have, I know especially for our above the knee amputees, sometimes they have to wear what's called a TES belt or a suspension belt across their waist. Some of my runners, my above the knee amputee runners, will do this to help control rotation, but certainly can be applied to water sports as well. Steve says, went canoeing a couple of weeks ago. My friend part of the pool noodle tied around my prosthetic. I like that idea. Guys, I like these ideas on how to give your prosthesis a flotation device in case it does fall off. Another thing I've seen done before, if you guys have ever, watched surfing or whatever, the surfers will connect to their surfboard with like a Velcro strap around their leg. So I have seen in some cases where a prosthetist will put some sort of a device and it'll attach to the person's wrist. Again, there's a couple of different ways you can try this out, just maintaining water safety. And I would say, guys, because I'm a former lifeguard here, so that's kind of a big thing for me is water safety, is if you are going to try any of these ways of keeping the leg on, draft shuts the door quickly. Making sure that if the leg falls off, that it doesn't cause you harm. As much as we value the prosthetic legs, your life is worth more than any prosthetic leg. So if any of these ways of attaching the leg can actually be a harm to you in the water, please keep that scenario in mind when you're designing ways to keep your leg on and talk to your prosthetist about this. Let's see. Robert says, my next adventure is going zip lining. I love it. Oh, and Marty's going skydiving. Y'all are awesome. Daniel says, I am a left above the knee and I keep my prosthetic legs shorter so I don't catch my foot on the swing phase. Now I have pain in my lower right back. Could that be from my hips not being aligned? Yes. And I'm going to speak on this because this is a little bit of a soapbox for me, Daniel. And again, I'm not blaming you on this because this is a very common thing to happen. So a lot of folks, when they come to see me as an above the knee amputee, they have these beautiful prosthetic knees, right? Whether it's a mechanical knee or a microprocessor knee, our technology is really, really kind of nice now with these prosthetic knees. And people will be walking in and just kind of, swinging the leg around and not bending the knee because they're afraid. They're afraid of bending the knee. They're afraid of the knee buckling. They're afraid of catching their toes when they swing the leg out. And I joked around with my patients and I'm like, it's like driving a Ferrari in first gear and like burning the clutch and grinding the gears. It's just like, right? You got to learn how to drive that prosthetic knee. You really do. And it opens up a whole world of mobility, knowing and understanding your prosthetic knee, understanding how that knee is supposed to bend, right? Does it bend because you stretch your leg? and put it in a certain position? Does it bend because you're loading and putting the weight into that toe and it allows you to release that leg? How you line up your leg before it goes into the swing phase. It's all these little details that really make a difference in understanding how your knee works, right? Devil, it really is in the details when it comes to the prosthetic knee. So yes, Daniel, I have seen lots of times where prosthetists will shorten the prosthetic side a little bit to allow their patient to swing the leg through. And all due respect to the prosthetist, I think they're doing the patients a huge disservice for this, okay? The best thing is to teach the patient how to use the knee. It does take longer. It does take a lot of work. Yes. Okay. The easy way out is to shorten the prosthetic leg. Okay. And I've seen it done. And I have to say, I don't agree with that approach. I really don't. At that point, a prosthetist should be forming a relationship with the physical therapist and referring their patient for gait training. Now, is there ever a case where I would agree for the prosthetic leg to be set a little shorter? Yes. And usually it's for my really older folks, my older generation, folks that are in their 80s and 90s, or perhaps folks that really have very, very poor mobility, and they're very, very unsafe. And this is just the safest way that we can get them to use their prosthetic leg. But again, very rarely do I ever recommend that a prosthetic leg be set shorter to allow those toes to swing through. And Daniel, as you can see, yes, unfortunately, that back pain is coming from your leg not being aligned correctly. It really is. So Daniel, I am going to plead with you, please find a physical therapist who can work with amputees, who can teach you how to really get comfortable using that knee. And you would be surprised, guys, about 80% of my patients that come in complaining of back pain, it's because of some flavor of gait deviation. And guys, I don't consider myself to be a back pain specialist. I have colleagues who run circles around me and twice on Sunday with how they treat back pain. But when I see amputees with back pain, most of the time it's because of a gait deviation. And when we correct that gait deviation, whether it's because something is not aligned properly with the prosthesis or because there's a deficit in strength, or in many cases both, we start to see a lot of resolution of that back pain. Okay, so Daniel, that is my humble begging you. Go see a physical therapist, talk to your prosthetist about learning how to use that prosthetic knee, and find that therapist that can teach you how to use that knee properly and confidently. And you're going to be amazed at how more efficient and more comfortable you're going to become with walking around. Steve says, just curious, I thought phantom pain is a lot when you do a lot of walking work on your leg. I just started getting phantom pain on my leg when I wasn't doing anything, and I thought it was weird. Thank you, Steve. And actually, that cues me for one of the first questions. Here we go. So one of the questions, I got a lot of questions here, guys. So like I said, get comfortable. All right. So one of the questions was, do phantom pains get worse and last longer during a stormy weekend? I'm sorry, I didn't know anyone else to ask. Yes. So I've done quite a few shows on phantom limb pain. And guys, if you go to my YouTube channel, it's under COSI Talks, which I'm live there right now. By the way, I know Daniel, you're watching me from YouTube channel. Steve, you're watching me from the YouTube channel. I've done several videos, full length shows, and also smaller, shorter videos on phantom limb pain. Okay. So for me, the biggest thing to understand is the difference between phantom limb pain, phantom limb sensation, and residual limb pain. Phantom limb, let's start with phantom limb sensation. It's when you can feel your foot, even though it's no longer there. Okay. And I get so many patients that come in and they'll be like, you're going to think I'm crazy, but why do I feel my toes? They're not there anymore. And I'm like, you're not crazy. It's your brain trying to process the information. Okay. So basically, when you lose your limb, the place in your brain that used to process foot sensation, it's trying to figure things out again. Okay. It's trying to kind of reorganize itself. We call that neuroplasticity, right? So your brain is just kind of trying to figure out, all right, there used to be a foot there. Foot's not there anymore, but we still have that part of our brain that recognizes the foot, right? So phantom pain sensation is that you feel the foot, you might feel some pressure on the foot, you might even feel it tickling a little bit, but you just feel it. There's no pain. With the phantom limb pain, you feel the pain, right? It can be crushing, burning, stabbing, tearing, electrical pain, It can be very mild. It can be very debilitating. It can be every once in a while. It can be constant pain. Everybody presents just a little bit differently. Okay. And then you have residual limb pain. Residual limb pain is pain that you feel in the limb that is still there. Okay. And you can point to it and say, I feel the pain right here. Okay. So in one of my videos, I go into more detail explaining all this. Now, the tricky thing is sometimes residual limb pain can trigger phantom limb pain. All right. And it's really important to try to understand where it's coming from. Okay. Is your phantom limb pain the result of your brain trying to figure things out? Or is it because there's something in your residual limb that's causing the phantom limb pain? Something like a neuroma, a bone spur, scar tissue. Okay, so these are all things that can kind of trigger these things. So once you've determined, Fred, you are just getting in my way, son. We're going to have to put you over here for now. All right. So once you've determined what it is that you have, whether it's phantom limb pain, sensation, or residual limb pain, then it can kind of start to narrow down, like, how can you address it? Okay. So the person here who indicated the pain gets worse and lasts longer during a stormy weekend. So once we've determined, is it phantom pain, residual limb pain, then I like to say, what is the trigger? Let's see if we can identify what the trigger is. And sometimes patients can tell me right away, stormy weather, boom, that causes my phantom limb pain. Other times my patients are like, haven't figured it out yet. In which case I have them start just writing a log down. When you have pain, how long does it last? What is it that you did that day? Did you eat something? Were you getting sick? Were you under a lot of stress? That's probably the number one. If I had to pick one thing, the number one cause of phantom limb pain is stress. Okay. Phantom limb pain brought on by stress. Okay. And then the second thing we try to figure out is there anything that relieves the phantom limb pain or makes it worse? Right? Hot pack and cold pack are usually some of the first things that my patients will try. And sometimes they'll find, oh yeah, cold pack calms that pain down. Other people will say, cold pack sends the phantom limb through the roof, right? Phantom limb pain through the roof. So again, part of, I think, the success of managing phantom limb pain, and notice I didn't say getting rid of it, but managing it, is understanding its origin, what causes it, and then trying the different things to relieve the phantom limb pain. Okay. And again, this is something that I don't think I've ever met two amputees with the same kind of phantom limb pain. To me, it's as individual and unique as a fingerprint. I've never met two amputees with the same combination of sensation of phantom limb pain, causes, triggers, relief. Right? I always say the person who can find the cure for phantom limb pain and truly understand it, they're going to be so rich, they're going to own their own island. Right? All right. So we've got, so Steve, in your case, if you have phantom pain that is being triggered after you've been walking for a really long time, it could be that your body is just expressing weakness in that regard. So for example, if you have certain muscle groups that are weak, okay, and your phantom pain is triggered because you're experiencing that fatigue. And again, that's a type of stress. A lot of people think that when I say, oh, stress can trigger phantom pain, you might think, oh, stress from bills or stress from family problems, which it can. But stress can also be just physical stress from the pressure dropping in the atmosphere when a storm is coming. Stress can be brought on by you're catching a cold or you're getting the flu. A lot of you, when you got COVID, you also had a flare up in your phantom limb pain symptoms, right? So stress can be brought on from many different things, right? Talking about it, I know, Linda, and I always feel bad because whenever we have a discussion on phantom limb pain, there's inevitably some folks in the audience that say, Kosi, zip it because I'm starting to feel it coming on just by hearing you talk about it. Yeah. And again, it truly is a bit of a medical mystery in terms of how the brain works, how it rewires itself, and how it interprets the body after amputation. So guys, again, if you want more information on, my thoughts on phantom limb pain, different options for treating phantom limb pain, please go check out my YouTube channel. I do talk a lot about it there. And yes, so then once you find out, what the triggers are, then, addressing those triggers. Okay. And it sounds like master of the obvious, but a lot of times when you're in the middle of that pain, it's kind of hard to see some of the solutions that might be available. All right. So let's get to the hallmark question of this evening. Please hold. Okay. So Emily asks, can you talk a little bit about CHF and how to manage it, and some exercises that you use for patients with CHF? CHF being congestive heart failure. My mom isn't an amputee, but was recently diagnosed with CHF and trying to learn as much as I can about it so my sister and I can help my mom adapt to her new normal. So quick COSI poll. Is there anybody here who feels comfortable sharing that is experiencing CHF or has had some experience with that? All right, so I'm going to post one of my pictures. I'm going to give you guys the COSI Talks 101 on the anatomy of the heart. So I'm going to give you a picture of the heart, and I'm going to show you just a quick review on how the heart works, because then it'll make it easy to understand what congestive heart failure is. So let's see. Patricia says, mine is when I'm wearing the leg, it cuts the circulation off that the foot is not there. And guys, before I move on to the heart thing, one more thing about the phantom pain. A lot of times phantom pain can be triggered by a prosthesis that is too tight. So if you're feeling phantom limb pain while you're wearing your prosthesis, that is something that you should check for to make sure that your prosthesis is not strangling your residual limb. Something to think about. Okay, so Scott says, I do. All right, so let's take a look at the heart. Okay. So it looks a little complicated, guys, but it's actually not terribly complicated once you break it down, okay? So if you look at the heart, you're going to see that there's 4 chambers. You've got a right atrium, a left atrium, a right ventricle, and a left ventricle, right? And you have lots of blood vessels that bring the blood into the heart, and you have blood vessels that take the blood out of the heart. Okay. So let's talk a little bit about how that works. All right. So when the blood comes in from the body, it's coming in from the superior and inferior vena cava. Okay, so you guys, I love this picture because it's labeled really beautifully. Okay, so if you look at the superior vena cava and the inferior vena cava, those 2 vessels are bringing all the blood in from the body, and it's dumping it into the right atrium. Okay, right atrium, the blood's going to go through that little tricuspid valve and into the right ventricle. The right ventricle is going to pump the blood into the pulmonary artery and out into the lungs. This is where you get the oxygen and that into the lungs and everything there. Okay. So from the lungs, it's going to come back into the heart, into the left atrium, into the left ventricle, and then back out to the body through the aorta. Okay. So it's kind of like a plumbing system. That's really how you have to think of your heart. It's a plumbing system, and it's pumping this way. Okay. Now, if you look at the ventricles, those are the ones at the bottom. You have that right ventricle and the left ventricle. Okay. So those are the strongest parts of the heart. Those are the ones that really have to pump the blood either into the lungs or pump the blood into the body. Okay. So what happens if there's any kind of cardiac sickness? Okay. And there can be lots of ways that the heart can be sick. It can be sick from a long hypertension, people who have high blood pressure that's not controlled, people who have heart attacks where some of that heart tissue dies, people who have disease of the valves. So if you see in between the atrium and the ventricles, there are those little valves right there, right? So if you have any problems going on with the valves, if you have an arrhythmia, okay, so arrhythmia meaning your heart is not beating normally. You know, your heart should be going do-doom, 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 right? 60 to 80 beats per minute. People who have arrhythmia might have a very high, fast heart rate or a very low heart rate, and it's not stable. Okay. So these are lots of things that can kind of throw the heart for a loop. Okay. So if the heart becomes injured, right? And let's talk about the left side. Sorry, I'm looking at this from a mirror standpoint, so I always have to think about it. Okay. So when we look at the left side, right, that left ventricle, okay, and it's going out into the body, right? And it's taking blood in from the lungs. If the right ventricle becomes, or excuse me, the left ventricle becomes injured, then the blood is going to get backed up into the lungs. Okay. And this is where we get what's called pulmonary edema. People are going to have a hard time breathing because they have all that fluid that is collecting in their lungs. Okay. If a person has right-sided heart failure or congestive heart failure, then all that blood is backing up into their body. So they're going to get a lot of swelling in their legs, their hands, and their abdomen. It's what we call ascites. Okay. So this is kind of what happens is basically in a nutshell. Let me go back to the regular picture. So in a nutshell, if your heart is sick and it's not pumping properly, it starts to back up. So remember how I said the heart is kind of like really cool plumbing? It's exactly that. If the water is not going clearly through your plumbing and it starts to get backed up, then you start to get a backup in another part of your system. Okay. And that's what's happening. Okay. Now, there are other things that can be affected in terms of how much blood is being pumped out, and that's called ejection fraction. You might hear that, and it's expressed as a percentage. Normal ejection fraction is about 55%, if I'm digging back into my files there, right? So these are some of the numbers and some of the words that you might hear a cardiologist talk about. Okay. Now, with very severe congestive heart failure, somebody might become a candidate for a heart transplant. And a lot of that depends upon what is causing the heart failure, what is the person's overall condition aside from the heart failure. And there's a lot of things that go into that. And I used to work in the cardiac transplant unit as well. Okay. So a lot of things to consider here. Obviously, the utmost importance with anybody who has been diagnosed with heart failure is working closely with that cardiac team, with the medications that are involved and balancing those medications. Okay. When it comes to exercise, a lot of people think that because a person has heart failure or a heart condition, that they can no longer exercise. And that's not true. Okay. When we think of the heart, we have to remember the heart is a muscle. It's a very specialized muscle. It's cardiac muscle, right? We have 3 different kinds of muscle in our body: cardiac muscle, skeletal muscle. So those are the biceps and triceps type muscles. And then we have smooth muscle that's located inside of our arteries and things like that. So the cardiac muscle is a muscle at the end of the day. Okay. And to keep a muscle healthy, you have to work the muscle. Now, obviously, if somebody has cardiac disease, you're working that cardiac muscle very, very carefully. Okay. And there are actually physical therapists who specialize in cardiac care. They go and they obtain an additional specialty. And those physical therapists, those guys are like rock stars, in my opinion. They read EKGs. They do all of these incredible things to keep their patients healthy. Okay. So if you are someone who has cardiac disease, okay, you need to, first of all, you need to let your physical therapist know about that, because we need to have this in the back of our minds when we're working with patients. Okay. And you also need to ask and work with your cardiology team about how you can keep your heart as healthy as possible with exercise, nutrition, and the right medical management. Okay. 3-prong thing. Okay. Something to consider if you're an amputee who also has a cardiac condition is the fact that you are going to be working a little bit harder. Okay, so as an amputee, many of you guys are understanding that you have to work harder to walk than a person who is not an amputee, right? You have to expend more energy than a person walking with 2 legs. Okay, so if you are someone with a cardiac condition or a lung condition or kidney condition, you need to work even extra closely with your team to find out what are your parameters. Okay. If you have congestive heart failure, do you have a certain heart rate that your cardiologist wants you to stay with? Okay. So whenever I would have a cardiac patient on my census, I would always look to see in the notes, are there recommended blood pressure and heart rate parameters? Okay. That we need to stay in when I'm working with the patient. Right. And I would teach my patient, what are these parameters, right? Does your doctor want your heart rate to stay under 80 or your blood pressure under a certain amount? Okay. So teaching my patients how to monitor themselves is very important. understanding medications, guys, because these cardiac medications, woo, they have a lot of side effects, okay? And understanding what those side effects are, okay, and how to monitor yourself for that. Or in the case of Emily, if you are the caregiver for someone, what is it that you need to look for in side effects when you have someone with cardiac medication? Okay, because sometimes these cardiac medications can artificially lower the heart rate, and you need to be aware of that. Okay, there are also cardiac medications that if they become toxic to the system, the person will present with certain symptoms. Okay, so understanding medications is really, really important if there is a congestive heart failure. Okay, and then working with the physical therapist. For me, I think probably, and I've done this on the show a couple of times, whenever I had a congestive heart failure patient or a heart transplant patient or a patient who had just had bypass surgery or someone with COPD, a lot of times I have them keep a daily log of how much they're walking and how they're moving and how they're feeling. Okay, because that's how I can assess how they're progressing or not progressing. Okay, so I encourage folks to do that, and it's a very simple log. Usually I would have the person write down how many feet they were walking per day, and I would give them some assignment. I would teach them how to monitor their heart rate before, during, and after the exercise, and also monitor their perceived exertion. Okay, so there's ways to monitor these things just to keep track of these things. Okay, so another reason why we kind of keep a close eye on our CHF folks is because they can sometimes present with an exacerbation, meaning a CHF crisis, right? So somebody who is monitoring themselves and knows what to expect, if they do have a crisis, they'll be able to pick up on it right away and get help from their doctors right away. I don't know if you guys can hear that thunderstorm. We have a really awesome thunderstorm right now, so I don't know if you guys can hear that. So I apologize if it's like interrupting. So Emily says, my mom had swelling in her legs and fluid on her lungs. They put her on Lasix now, and the fluid is reducing. She never had to see a cardiologist until now. So yeah, so Lasix is a diuretic. So basically it's siphoning that fluid out of the body so that the person can breathe again. Okay. So, again, going back to being in high altitude elevation, and just feeling my lungs not being able to get the amount of oxygen that they were normally used to getting. Right? That's what it feels like for a congestive heart failure patient or a patient with COPD, chronic obstructive pulmonary disorder. Okay. So again, understanding the whys behind it and then how to monitor. And the other thing is, guys, like I remember as a fresh new physical therapist, I rotated through the cardiac critical care unit. So we had people there who were freshly transplanted, people who had just had, quadruple bypass surgery. And then for me, the scariest patients were the ones that were waiting for the heart transplant. I mean, that they were literally on death's door. And they were either hours or days away from dying if they didn't get a heart transplant. And I was very nervous as a young therapist going, oh dear, like I don't want to harm this patient anymore. But it was something that I had a wonderful mentor. Her name was Tai Mei. And she was just a phenomenal physical therapist who taught me, not to be afraid of working with CHF patients and patients that we have to be very careful with them, right? And that as long as we stick to those parameters that the doctors give us, that we can work with these patients and help them be successful with maintaining their mobility, right? So it's a very interesting thing. Let's see. Ben Gregory is asking, can one use breathing through a straw method to increase oxygen saturation during strenuous exercise like a stunt at high altitude? Oh, he saw the program. Okay, he saw the reel. So guys, let me just kind of flip back to what Ben Gregory is talking about. Okay, so one of the things is especially, and this is more so with my COPD patients, is that they're retaining carbon dioxide, right? They're not able to expel the carbon dioxide. And that's partially what makes their oxygen saturation go down. Okay. So when we take that oxygen in, we need to have it carried through our body through the red blood cells. If we're not expelling carbon dioxide, we start to feel woozy and toxic and we feel bad. Okay. This is what happens when people suffocate. It's because they're retaining that carbon dioxide. It's what happens when you go to high altitude is you're not getting in enough oxygen. So one of the methods that I use with my COPD patients when they're starting to kind of feel suffocated is I have them do what's called pursed lip breathing. Okay. And it's basically, I tell my patients, pretend that they are breathing through a straw, which I know this isn't a straw, but basically you purse your lips real funny like this. And then you take a deep breath in and push the air out. Okay, as if you are sucking in through a straw and blowing out through a straw. And what that does is that helps you with your exchange of gases. So it helps you push that carbon dioxide out and it helps you pull in the oxygen better. It's not a cure for this. It's not a cure-all thing, but it does help sometimes, especially if a person's having an episode when they're feeling very anxious because they don't feel like they're getting enough oxygen in. So that can be helpful. During strenuous exercise, Ben Gregory, if you're not someone who has cardiac issues, that could help, but at the same time, it might not allow you to get enough oxygen in. So it's fun to kind of experiment with that and just to see how it makes you feel. Yeah. See, Chuck says cardiac rehab as an outpatient is an excellent option if available in your area. Heck yeah. The person following her can give the safety parameters specific for her. Absolutely. For me, I think cardiac nurses and cardiac PTs, rock stars. And I don't think I've ever worked in, and I've worked in several cardiac outpatient units. I don't think I've ever worked in one where the nurses or the PTs weren't rock stars. And they're really, truly amazing. And a lot of people would think like, well, they're just walking. What is so specialized about that? And it's like, well, they've got EKGs and they're monitoring your heart rhythm the entire time. And they're slowly increasing how much exercise that you can do for your heart. And I'll tell you what, it really, for someone who's, especially people who've just had quadruple bypasses or heart transplants, this gives them their lives back. So Emily says she was getting outpatient PT before entering the hospital, and we're hoping that they can continue that once she is home. Yeah. So that was kind of a fun walk down memory lane. It's been quite a while since I've kind of dug deep into cardiac issues, but it's a really very cool subject. And it's, again, something that many people, that are understandably anxious and afraid of cardiac disease, right? Some patients have expressed to me that they feel like they are, ticking time bombs. So being able to teach patients how to understand their cardiac disease, how to monitor themselves, how to understand the medications that they're on, and then what they can be doing from a lifestyle standpoint to improve the health of their heart. I feel like it gives people a little bit more empowerment, a little more confidence in moving forward with that. Let's see what else. We got a lot of folks listening in on Instagram, guys. Instagram, don't be shy, man. Give me a shout out, guys. Give me a shout out. All right, let's see. There was another question here. I've got like 3 pages of questions here. Oh, wait, there was one. Okay, now I remember where that other cardiac question was. Okay. Oh, that was a very loud crackle thunder. Did you guys hear that? Okay, so Andrea was asking, is there a magic number for heart function needed for successful use of an above-the-knee leg, especially an elderly person? And this is a 2-part question, so I'm going to answer that part. Yes and no, Andrea. When it comes to working with cardiac patients who are amputees, you use the same parameters. Okay. And this is interesting. I remember I got into an argument once because somebody was surprised, me getting into an argument with someone about amputee. Because I can't remember if it was the prosthetist or the doctor, that they said they would not allow the patient to use the leg because it would cause too much stress on their heart. And I just remember thinking to myself, what a stupid clinician to say that. Sorry, guys. I don't have much of a filter. But if you think about it, guys, you go by the parameters. Okay. So if a surgeon tells you, or a cardiologist tells you, I don't want my patient's heart rate to go above 80, then you start very slowly. Okay. And you monitor your patient. You don't just start by throwing them in a leg and getting them in the parallel bars and working them. You start very gradually and very slowly. Okay. And if you think about it, having to hop around on one leg and a walker, that also causes a lot of stress. That's what the conversation was. Now remember it, where it was the doctor saying that they didn't want the patient walking around in a prosthesis because it was going to be too much stress. So they wanted the patient to use crutches or a walker. Pause for effect, right? And I know all of you out there right now, all of you who are amputees, that you've had to at some point or other use crutches or a walker with one leg. Tell me that that's not added stress to you, right? So it's one of those things where, you have to kind of just as a clinician, you just kind of step back and say, okay, what are the parameters? Okay, if these are my working parameters, I have to keep my patient's heart rate within this range. I have to keep their blood pressure within this range. Then we start at square one. And it may just be that the person is just sitting up at the edge of the bed and you start working with them there and you're monitoring them the whole time. Okay. Guys, those of you who have worked in acute care units, and you know this, whether you're working in a post-op surgical unit or you're working in the med surg floors, you don't just whip your patient up out of bed and get them going. You start off nice and slow and you monitor them that way. Okay. And yeah, when it comes to using a prosthetic leg, there is going to be more energy expenditure, but certainly just as much if they're hopping around using a walker and having to put pressure onto their arms to support their body with a walker. Okay. So in terms of magic number, it's more, again, it goes back to the parameters. A lot of times we look at ejection fraction and when we worked in the cardiac care unit, the percentage of ejection fraction certainly told us a lot about how the patient was doing. So the lower the ejection fraction, the more careful we had to be with the patient because it meant that their heart was not pumping enough blood out. Right. So we had to be very careful with that. And again, it just goes back to look at your patient, look at the parameters that you are being given. Okay, I've had patients with as little ejection fraction as 5%. So these are the ones that, like I said earlier, they were knocking on death's door. They were waiting for that phone call for that transplant. They were loaded up with a lot of medications in that cardiac care unit. So obviously we took it very, very slowly and very carefully with these patients, and we watched them like a hawk whenever we were working with them. So again, as little as 5%. But I remember the cardiologist saying this patient has to continue to move as little as possible as they can, but they need to continue moving. Okay. So for me, I don't think there really necessarily is a magic number. Again, I'm not a cardiac specialist in terms of physical therapist, but I worked with a lot of cardiac patients. It's more about what is the patient allowed to do and what is the cardiologist telling me that we have to do for them. Yeah, Emily says, as a lifelong crutch user, I can confirm that it's a lot of work, right? And the thing is, with a lot of your cardiac patients, part of your cardiac precautions are don't put pressure on your arms. So if you're using a walker and crutches, yeah. So Emily says, that's how I feel when my mom was diagnosed, especially since I'd already lost my dad 7 years ago. Yeah. And it can be scary. We recently had in someone in my family who underwent quadruple bypass, and it scared all of us. And it scared, the person who had to undergo that surgery. It's not to be taken lightly. But it doesn't mean that it's not manageable, and it doesn't mean that the person cannot live life afterwards. But yes, there are changes that would have to be made and a lot of precautions that need to be observed as a result, right? All right, let's go to the second part of the question that Andrea had, which was, have you ever felt someone is just not a good candidate for an above the knee leg? Who should bring this up? You hate to squash hope, but the determination, physical ability, cost, and possible limited therapy all plays a role in success, especially with older and somewhat chronically ill people. Tough cases at work in the past few months. If someone can be more independent at a wheeled level, power manual, should that be presented as an option? Yes. And guys, if you can't tell this particular question, sorry, I'm trying to get back to my screen without like knocking out the show. This is coming from a clinician, and this is definitely a scenario that as clinicians, we face a lot, both physical therapists and occupational therapists. Is there ever a time where you do not recommend the use of a prosthesis for an individual? And this is something actually in the course that I gave recently, we spoke quite at length about this. There are a few times where a prosthetic leg may not be recommended. Okay. First and foremost, if the person is bedbound, if they are completely living their life in a bed, they are not leaving the bed for any reason. Okay. So this is usually in the very, very old, the very frail, the very sick, end of life. Okay. And that might seem like master of the obvious, but in my home health days, I did on occasion walk into a patient room where the patient was bedbound and was not going to ever leave their bed again. And they had been ordered a prosthetic leg, and the prosthetic leg was issued. And yeah, I do take issue with something like that. Outside of that scenario, most of the times, I think there can be some benefit to a prosthesis. Okay. Obviously, our higher active folks, for sure, prosthetic use. But even for our folks with low mobility, and the first person that comes to my mind is probably my oldest amputee patient. He was a 96-year-old above the knee amputee. He wasn't my oldest patient. My oldest patient I've ever had was 102 years old. One of my last World War II veterans. But anyways, this particular 96-year-old, he was obviously not a spry spring chicken. He wasn't running around doing cartwheels, but he was using a very simple prosthetic leg. And the whole point of his leg was just so he could move from point A to point B in his home. And it was easier for him to do that. He had retained enough mobility that he was able to stand with a walker, and he was able to take a few steps at a time with his caregiver. So when he came to see me, that's exactly what we worked on. And in the beginning, we actually locked his knee in extension. And this is one of those very few times that I'll do that, right? And in his case, we set the prosthesis just a little bit shorter. Okay, so remember how I said there's occasionally a time where that might happen? That was one of those cases, okay? And mainly because he was very nervous, he was very anxious, but he was still very driven and wanted to use a prosthetic device. And then also in his case, for being 96, he was very, very sharp, but his safety awareness was not wonderful. Okay. So this was a case where we kind of looked at the whole picture and we said, okay, he wants to use a prosthesis. We can set him up with a very simple prosthetic device. We will lock it in extension, and we will work with him and his caregiver to teach him how to walk safely with a walker. And then, over the course of about a month and a half, we were actually able to unlock his knee and teach him how to bend the knee a little bit at a time. So even there, we were able to get a little bit improved function. Okay. There are other folks where they will use the prosthetic leg to transfer. Okay. So if it's someone who's very low mobility and they are dependent on a caregiver, they have a full-time caregiver to help them from out of the bed into the chair. Sometimes it's easier to use a prosthetic leg because they can stand up on it and pivot. Okay. So in low mobility cases like that, I look at the patient, but I also look at the caregiver or the family member who is taking care of the patient and work together with them and say, okay, what is going to be the easiest way that we can help you move the patient and the safest way for both the patient and the caregiver? Okay. Now, there have been times where I walked into a patient home and I said, I think this patient would do well with a prosthesis just to stand and pivot. And the caregiver said, no. That the caregiver was just simply overwhelmed and they were already accustomed to transferring the patient without a prosthesis. And in their case, they said, we don't want that because it's just not going to be helpful to us. And you respect those decisions. Okay. The other case scenario is if the patient does not have the mental capacity, right? So obviously any of you who are watching right now who have learned to use a prosthetic device, you got to kind of have your wits about you, right? You have to learn how to use the prosthesis. You have to work hard at it. You have to practice. There's a lot of mental exercise involved with learning to use a prosthesis. And there are some folks, whether it's because they're experiencing dementia or perhaps they had a traumatic brain injury that's very severe, that they are not able to learn how to use a prosthesis and it's not safe for them to do so. Okay. So these are just some of the scenarios. Now, going back to what Andrea asked, is there ever a time where wheelchair mobility might be the option? And the answer is yes. I find a lot of times with my bilateral above the knee patients, I have this discussion with them. Okay. And guys, it all starts for me. It all starts when I first see the patient and I say, what are your goals? Whether I'm seeing a patient as a home health therapist or whether I'm seeing them fresh out of the OR in the acute care unit or whether I'm seeing them weeks to months later in my outpatient clinic. What are my patient's goals? Okay. And I've had some patients who are double amputees that they say, you know what? I've seen how hard it is to try to walk with two prosthetic devices. I'm not interested, or I only want to learn to use them enough just to kind of move around my house. But I want to use a wheelchair. And I say, let's do it. Okay. And then sometimes I have the opposite where I have a person who's really, really motivated. They want to learn how to use two prosthetic devices and we work and work and work. But, over the course of time, the patient starts to realize, I might want to look into other options for mobility. And to me, guys, I don't see wheelchair as a failure. I see wheelchair as a tool for independence. Okay. So for many of my patients who are bilateral above the knee amputees, learning how to use a wheelchair allows them to become independent in their home and independent in their community where they don't have to rely upon a caregiver. And a lot of times with my bilateral folks as well, they have options. Sometimes they'll use their legs, sometimes they'll use their wheelchair, and they just like having options. And I think that's honestly, as clinicians, the best thing we can do is give our patients those options. It is sometimes a little uncomfortable to have these conversations because especially if you have someone who really wants to achieve a high level of mobility and they're not there yet, and they may not necessarily achieve that level of mobility that they're hoping for. So as a clinician, it's hard. Yeah, it is hard having to have those conversations, and you try your best to be compassionate, and not to dash hopes, right? And to also try to work with them as best they can. And that being said, guys, I've had some folks where, they came in with very lofty goals. And on the inside of my brain, I'm going, oh dear, I don't think this is going to be possible for them. And then they surprised me. Even after over 23 years of working with amputees. So again, it's something, I think it's a work in progress for me on how I continue to communicate with my patients and work with them and try to give them as many options as possible. So Ed says, I have a bilateral AK who spends 1/3 of his day in the wheelchair, 1/3 of his day on his stubbies, and 1/3 of his day on his prosthetics. Exactly. And that's a lot of times what I see. And to me, guys, I feel like that's a win because they're able to use all of these devices and adjust them accordingly to what their mobility needs are. Okay. And then you have other folks like Susan. I'm going to put you on the spot a little bit because you're just amazing. You're just amazing. Susan is a petite little peanut and she walks as a bilateral above the knee amputee. She's a bilateral osseointegration and she's just amazing. She's an amazing human being, and she constantly amazes me with her physical strength, her emotional strength, and her spiritual strength. So Susan, if you're still on board, I know I'm embarrassing you just a little bit, but again, amazing. And I think that's one of the reasons why I know I like being a therapist and being amazed by my patients, by how they adapt and how they continue to live their lives. So guys, for my therapists out there, please continue to give comments because I love hearing from my fellow physical therapists. Okay, so Pastor David, I hope you're still here. I love having Pastor David on board. Let's see, let me check my Instagram. We got a lot of people listening on Instagram, but they're awfully quiet. Let's see. Pastor David is asking, do you have any suggestions for improving an above-the-knee amputee's ability to navigate inclines? Going up is not a problem, but going down can be challenging. I know inclines come in many and varying degrees of slope. Yes. And it was interesting as when I first started working with amputees, I thought to myself, boy, going upstairs is so hard. It must be so much easier going up ramps. And I learned real quick that is not the case. So quick COSI poll, guys. How many of you, what do you think is harder, stairs or ramps? Put it in the comment section. Put it in the comment section. I know what the answer is going to be, but I want to see you guys write it. Emily says, I met Susan at my amputee support group, and she and Marshall are amazing. They really are. They are the dynamic duo right there. All right. So guys, y'all need to put some questions. You need to put it in the comment section. Don't leave me hanging, guys. Don't leave me hanging. It's like always a delay. Haha, there we go. Harsh coming in with ramps. So ironically enough, Pam is saying ramps, David is saying ramps. When I'm working on the higher level activities with my patients, I work on stairs first. And that sounds like a little like, what? Really? Over ramps? Yes. Christy says little hills. Chuck says ramps. Everybody's saying ramps. Nobody's saying stairs because they are harder, right? Benny says it. Pamela's saying it. Marianne is saying it. Glenn says stairs. Now my sound knee is painful. Oh, Glenn, you got to take care of that knee, buddy. Debbie is saying ramps. Okay. So yes, ramps, kind of scary, whether you're below the knee or above the knee. So the way I teach people ramps is by just basically the same way you eat an elephant, one bite at a time, right? So if the person is on the ramp, right, I will start them at the very end of the ramp, And actually sometimes what I'll do is in the parallel bars, I'll put little like speed bumps, like several speed bumps like this on the parallel bars. And I'll have the person put their prosthetic foot on the speed bump to roll over the speed bump. Okay. And that kind of just helps them start to understand how their knee is going to work and how it feels, right? So what I do in general is I'll take the person after I do little speed bumps in the parallel bars, I'll take them to a ramp and I'll go to the lowest part, just the last part of the ramp, that one step. And I'll have them practice that one step. Now the kicker is going to be, guys, what kind of a prosthetic knee do you have? Okay. And this is the part where you have to do the fine tuning and you really have to start learning the nuts and bolts of your knee. Okay. So if you have a hydraulic knee, you have to learn to what's called riding the knee. You have to trust that knee and put your weight into it, which is really scary, right? Because if you don't put your entire weight into it, the knee's going to kind of buckle and not be there for you. Right? So it can be really scary when you're learning to use the ramps. But again, this is why we save this for the higher level mobility and towards the end of physical therapy treatment, right? When we're teaching someone how to walk. Okay. So understanding how that prosthetic knee works, Pastor David, that is what's going to allow you to learn how to do that incline confidently, right? Does your knee have to be, or does your hip have to be in a certain position to get the knee to bend? Do you have to put a certain amount of weight into that toe to get that knee to bend, right? So again, asking your prosthetist these questions. The other thing to consider, okay, is when you're getting, again, to that fine tuning of the walking and the higher level balance is your knee can be adjusted. So if you find that you're having a really hard time breaking the knee, getting it to bend and riding into that knee as you're going down the incline, it might be time for your prosthetist to make a little bit of an adjustment. Okay. And to practice. I mean, guys, I can't tell you, practice. Okay. So, but in general, right, you start at the end of the ramp and you just take that first step down off the ramp. And then you back up 2 steps, and then you take the 2 steps down. Now, guys, for emergency purposes, I always teach my patients different ways of going up and down ramps and stairs. Okay. So one way is to come down the ramp backwards. And I know that sounds really weird, but sometimes people have an easier time coming down backwards than coming down forwards. Sideways is the other way. Okay. Especially if there's a railing, and being able to come down sideways while you're holding the railing with 2 hands. Okay. So again, these are just emergency ways to getting up and down a ramp, especially if it's a ramp that's really, really, really steep. Okay. So again, safety is always the first thing to go. Harsh says, even string exercise hurts for some reasons. Yeah. And Daniel says ramps are way, way harder. Yeah, absolutely. But again, Pastor David, it's knowing how your knee works. Understanding how it works and having your prosthetist or your physical therapist explain it to you, then you can actually practice. Actually, and this is for folks who have a C leg. Ottobock has some really, really nice videos on their YouTube channel. And I love showing, like when I'm working with patients, sometimes I'll have patients look at the videos because I'm just like, it really demonstrates beautifully how to really activate that particular knee, the C leg. Okay, so if you happen to have a sea leg, go ahead and watch the Ottobock YouTube videos. Harsh says safety first, but action speaks louder than words. And this kind of segues into our next question. And this was a really great question because I was like, I think I've only had this question maybe once in the 7 years I've been doing this show. The question is, fires in a multi-story building, elevators down. What do we do if we're in a wheelchair or even new in prosthetics? Okay. So this is, this is a tough one, guys, because, and I remember I have a dear friend that when she was an above the knee amputee, relatively new, that I think the fire alarm in her house went off or something like that. And her son was thankfully this big strapping young man. He had to basically run into her bedroom, scoop her up and carry her out of the house down the stairs. And she was describing this to me and she was saying, how that really was a wake-up call for her of knowing that, like, if something happened in the middle of the night, how was she going to get out of her home? As an above the knee amputee going downstairs and like, oh my gosh, what if my son is not going to live with me forever? How do you manage these things? So this is something that I have covered with my patients in terms of when I talk about their accessibility in their home. How are they getting into their home? How are they mobilizing within their home itself? And like I said, I worked home health for many years and had to get creative. So this is definitely something you need to talk to your prosthetist and your physical therapist about, if you have any stairs in your home, if you live in a third floor apartment, how do you access these stairs and these exits? So a couple of things to consider. Number one, if you are going back to an apartment building where you're not on the first floor, the first thing I would do is have the social worker or the case manager talk to your landlord and possibly relocating to the first floor. I'm not sure about the legal side of things, but and again, guys, don't quote me on this one, like look this up and check this for yourself. But I believe there's something from the ADA standpoint that allows you to have a first floor dwelling and that your landlord should try to make that accommodation for you. Again, don't quote me on this, look this up. But I had several cases where patients were being discharged home and the social worker arranged for the patient to have an apartment on the first floor. Okay, so that's one of those first things. If that cannot be done, to work out an emergency exit system. There were, again, several times where I had to teach patients to go up and down stairs on their bottoms because either they didn't have their prosthesis yet, or when I worked in the trauma units, the person was not able to bear weight on their legs because they had multiple fractures or multiple injuries. So I literally was in the hospital stairwell teaching my patients how to go up the stairs on their bum and go down the stairs on their bum and how to get into a wheelchair afterwards. So this is something that, people are like, what? And I'm like, yeah, it'll get you from point A to point B safely, and especially in an emergency setting. And if wherever it is that you live, whether you live by yourself or you live with your family member, yeah, you need to talk about what happens what happens if there's a fire in the home. I would even go so far as to suggest, especially if you live by yourself, allowing your neighbors, alerting your neighbors to say, hey guys, remember, if something happens in the home, I don't have a leg. You guys got to let people know about that. Calling your local fire department. And again, this is something that I probably should learn myself. Does the fire department making them aware? Like, hey, this is who I am. I live in your district. If anything happens, please understand I don't have a leg. Okay. Even as far as putting, how some people have medical alert bracelets, especially if you live by yourself, putting a sign on your door or somewhere inside the door so that if a fire department has to break into your home to come get you, that they know this is where you are. Okay, so we're kind of going down pretty deep rabbit hole, but again, these are things that you got to kind of take into consideration on how to get out. Okay. David says, been on my butt many times going up and down the stairs before I got my prosthetic, whatever it took. Yeah. And again, guys, this is in no means like an amputation. I broke my foot when I was in college. I was doing something real stupid and I broke my foot and I was on crutches for weeks, and my parents live in a 2-story home. with really steep stairs. And even as a young, healthy 19-year-old, I just got tired of falling down on crutches using stairs. So I would just go up and down on my bum to get to my bedroom at night and come back down the stairs. No shame in that. Steve said he had bad sleep in my living room weather lately with rain. Just now we have a heat wave. Scott says I'm on the first floor, but it is one level. So I've had this concern, but I think I would be able to make it now. One level up. Yeah. Yeah. So guys, there's nothing, I think it's actually very reasonable to take this into consideration and to figure out, okay, and in a case of an emergency, worst case scenario, what do I do? What do I do? Okay. All right. Next. This question. I like this question. This question says, I watched your last live and you talked about your book. Do you have a link? Yes, I do. And I'll take it even one further. I've got a cool little QR code. Okay, there we go. All right, guys. So for those of you who are not yet familiar, I have what's called the COSI Talks Strong Body Program. And it's been a minute since we've talked about the COSI Talks Strong Body Program. So I'm going to take a moment to plug on my own show. So basically, guys, it's been 4 years now since I launched the program. When COVID came and all the shutdowns happened, lots of fitness programs, but nothing for our amputee population. And in my own clinic, I always had a lot of trouble sending my patients home with exercises because we really didn't have any software that was adapted for amputee exercises. So I made my own, and that's where the COSI Talk Strong Body Program comes into play. Y'all can start scanning that QR code, and I'm also going to go ahead and type in the website because I just realized that some of you are not able to do the QR code thing. So what is the COSI Talk Strong Body Program? It is 150 video exercises for above the knee and below the knee amputees. It's for arms, legs, core strengthening, balance, and flexibility. Okay, so these are all video exercises done by amputee models with yours truly giving directions on how to do the exercises. And it takes you from the first day after your surgery all the way through becoming an athlete and everything in between. So literally, this is your lifelong amputee fitness program. So these are exercises that I have done for my amputees from the minute they wake up in the recovery room all the way through teaching them how to run. And then there's 2 books. There's an above the knee book and a below the knee book. So for every video that you find in this program, there is a corresponding book entry. And the reason I did this is because I am a very visual learner. I like to see things in a book. I like to see things in a video, and that's when it starts to click in my brain. So that's how I designed this program. I also want you to know there's a lot of exercises that are with the prosthesis and without the prosthesis, because obviously everybody's at different stages. And even some of you who are proficient with using your prosthesis, sometimes some exercises are more comfortably done without the prosthesis. Okay. So the book is available on the website for sale. And then you can also get a subscription to the video exercise program. So it's been a while since I've talked about my program, and I realized I got to do it because there's really nothing else out there that I've seen for amputees for fitness. So these are exercises that I would also encourage you to take to your physical therapy sessions. So many of you have let me know that you would take these books or the exercise videos to your physical therapist who perhaps was not experienced working with amputees, and this helped a lot. And I've always told people when I've had physical therapists have contacted me saying, hey, I don't have amputee experience. Where do I go? And I tell them, if they have a license in physical therapy, they can open this book and start putting together a plan of care. So again, for those of you who are seeking physical therapy, and especially some of those of you tonight, Ken, Mr. Daniel, that y'all need to get yourself to a physical therapist, I highly recommend taking a look at these books in this program and taking it to your physical therapist to work together. So Chuck says, we took the book with us to physical therapy at first. Good. And then that's really how it works, guys. When people come to see me at my clinic, they get a subscription to the videos, and then the majority of people end up buying one of the books to keep with them. Let's see. Blue Diva says, one thing amputees are amazing at is adapting and finding hacks to get through daily life. We do what we have to. Great idea to let the local fire department. I also have a key safe just for emergency services. Yes. And guys, I have to say the fire department thing, that was something that one of my patients years ago told me about, that they're like, yeah, I made friends with the local fire department. So they knew who I was, and they knew that if, God forbid, anything was going on in my neighborhood, that there was going to be someone in there without a leg that they needed to take into account. So yes, absolutely. And especially, guys, for those of you who live by yourselves, or perhaps your family members are not strong enough to be able to, like the case of my friend, she had a strapping young son who could pick her up and carry her out. This is things to think about to keep yourself safe. All right, let's see. All right. I like this one. This person says, I don't really have a question, more of an update. Several weeks ago, I asked you for advice on my very large socket that didn't fit my small stump. I just wanted to let you know that I've changed prosthetists and will be getting my new socket coming this Monday. I'm looking forward to walking. Thanks for all your help. Guys, I can't tell you how much I enjoy reading these emails. So many of you send me emails through the week, and I try my best to answer them in a timely manner. And I always tell people when I answer their emails, please keep me posted. And guys, it's not just lip service. I really do like hearing the epilogue to whatever your story is. So for those of you who take the time to let me know what the follow-up is, whether good or bad, on the advice you received or where you are in your progress, please know that I really treasure that, and I appreciate you taking the time to do that. So thank you, guys, for those of you who return those messages. All right, let's see. I think, y'all, we got through 3 pages of questions. 3 pages of questions. That's pretty okay. I have a sneeze coming. Okay, so here's a housekeeping thing. If I could humbly ask folks, my texting service there we go. Okay, guys, if I could humbly ask you to please, if you have not already done so, sign up for my texting service. You text COSI Talks in all capital letters, just like that, to that particular number. It's becoming my favorite way to communicate with you. You can text me your questions. I can text you the links for whenever I go live. And also, if you're on there, it also means that when my sponsors are doing giveaways, you're going to be the first one to be on that giveaway. So I would ask you, please, if you haven't already done so, sign up for the texting. I don't spam your phone. I don't send like 5 text messages a day like some of these other services do. I am respectful of your texting space. But again, it's also a really great way to stay in touch with me. Okay. I think that I am talked out, which says a lot for this Cuban gal. All right, guys, if you can also do me a favor, share out this live video. If you're not already following me on Instagram or subscribed to my YouTube channel, please think about doing that as well. All right, guys. And with that being said, I am going to go ahead and sign off for this evening. As always, thank you for letting me be a part of your lives. I hope to see you all next week, same bat time.